Okay, so good evening, ladies and gentlemen. We're going to talk this evening about the new Canadian Cardiovascular Society guidelines that were presented at the Canadian Cardiovascular Society at the end of October. So I have to give my disclosures. I've received honoraria and consultation fees from Merck, AstraZeneca and Abbott, which is relevant for the present. So the major changes in the new guidelines are, firstly, that we're going to talk about the concept of vascular age. It's a concept which may help your patients to understand why it's so important that we give them statins to improve their prognosis. We're going to talk about a new target, non-HDL cholesterol. We're going to talk about new indications as high risk, and particularly the addition of chronic kidney disease and a lower age for starting statins in patients with diabetes. We're also going to talk about secondary testing in selected patients who you're not quite certain how to classify them as high or low risk. And we're going to talk about statin adverse effects, the aches and pains that all our patients seem to get. Now, the good news is that there aren't too many changes in the actual algorithm of treatment. So you all recognize this table of high, intermediate and low Framingham risks, considering treatment in all patients who are at high risk with target of less than 2 millimolar or 50% reduction in LDL, and alternative targets of ApoB, the intermediate risk treatment with the LDL of greater than 3.5, and then again the same targets of less than 2 millimolar or a 50% reduction of LDL, and then the low risk patients. So that table is pretty much the same as we've been looking at for the last 4 or 5 years. The one addition is the introduction of non-HDL cholesterol. I'm going to spend a little bit of time talking about that, but I just wanted to reassure you that people that write guidelines don't do it just to make major changes. They make to enhance the guidelines. They want to try and keep the guidelines pretty much the same as they were before, but to make a few additional changes to enhance or to add things which new evidence is to support. So largely these guidelines are the same with a few minor additions. And the minor additions I think are important ones, and we need to discuss those. So we have the first patient, who's a 43-year-old male. He's come for his annual health check, and he's got no prior medical history. He's an ex-smoker. He's got a family history of premature cardiovascular disease, with his father having an infarct at the age of 53. And he's a little bit overweight, isn't he? He's got an abdominal circumference of 105 centimeters, so he's got abdominal obesity. And I think for a 43-year-old man, you would agree his blood pressure is a little higher than he should be. Now, I'm not going to ask this rhetorical question, but I think you would all send this patient for a lipid profile. I don't see anybody saying they wouldn't. I think it's reasonable. And it fits in with the lipid guidelines. So the patients that we recommend for a lipid profile are all men over the age of 40, women over the age of 50 or postmenopausal, and all patients if they have cardiovascular risk, particularly smokers, patients with diabetes, hypertension, or with a family history of premature cardiovascular disease, moderate renal impairment, and particularly the patient with HIV on antiretroviral therapy. The question is, in those bottom ones, at what age do you start? You know, somebody who's got a father that had an infarct at the age of 40, when are you going to measure the lipids? What age? I don't know, the guidelines don't tell us. When do you do it? I'm going to ask you. Any ideas? Wait. Okay, you've got a fellow, comes into your office, he's 25 years old, his father had an infarct the year before at the age of 50. Would you measure his lipids?
Yes.
Okay, so if he was 15, would you measure his lipids? I see some heads shaking there saying no. So somewhere at around about 20, I think, is a reasonable time in somebody who's got a bad family history to check their lipids. Now, most of those patients, unless they had familial hypercholesterolemia, you probably wouldn't initiate treatment at that stage, but you'd follow very closely, and certainly if the individual was at high risk, you would try and get those risks down by other means. So, same patient. He has his blood sugars done, and his fasting blood sugar is 6.1. His A1C is 5.9%. So that tells us he's got impaired fasting glucose, and his A1C is a little too high for him. It's not in the diabetes range, but remember that there's a linear relationship between the A1C and cardiovascular risk, even below the level of diabetes. Okay, so we measure his lipids, and you can see he's got a slightly low HDL, and his LDL isn't all that bad. So you can see that his lipids are the typical lipids of a patient with metabolic syndrome. So he has a low HDL, triglycerides which are too high for him, and an LDL which isn't too bad. So looking at this fellow, what is he low risk? Is he intermediate risk, or is he high risk? What do you think? What do you think his framing, and should he be taking a statin? So, actually, before, how many of you would start this fellow on a statin? None of you? Okay.
Before, well, I mean, you might give him a chance to improve on his own.
All right. So, okay, so what are you going to get him to do?
Drop some weight, improve his diet.
His weight, so BMI is not too bad, but okay, all right.
He can. But if he dropped it down to 25 and he cut some fats out of his diet, he might improve that. If his triglycerides are the problem. If he drank, if he ate sweets, those affect triglycerides primarily. So you could try. Lifestyle doesn't do that. We should always do that, and you're absolutely right. We should do that, especially when it's sort of on the fence.
Yeah.
I mean,
right. No, I agree. Okay, so we need some more information, I would suggest. Okay, sorry.
You need his framing and risk score.
You're absolutely right. Okay. So yes, you need the framing and risk score, and here's the modified framing and risk score. So yes, we need to calculate it, but we also need to calculate the modified risk score. And the risk score that you need to get is the most updated one, which calculates total cardiovascular risk, because the previous one just calculated coronary risk. Remember that ladies have their heart attacks 10 years later than men, but they may have other cardiovascular events before that. So it gives a fairer estimate of risk according to gender. And we should, after all, we are interested in stroke as well. So you need to get the table which calculates total cardiovascular risk. Then determine, is there a family history of premature cardiovascular risk, coronary, cerebrovascular, or peripheral vascular disease in a first-degree relative, that's father, mother, or brothers and sisters, male less than 55, female less than 65, and with a positive family history of premature cardiovascular disease, we double the risk. So for this individual, here's the table that is in the Canadian Cardiovascular Society's guidelines, and you can see that he calculates, so this takes into account age, HDL levels, total cholesterol, blood pressure, whether the patient's treated or not, smoker, and whether he has diabetes. And you can see his total risk score is 8. And a score of 8 gives a 6.7% risk, but remember this fellow has a positive family history. So it brings it up to 13.4%. So we now know that this individual's risk is in the intermediate range. So I'm going to put you on the mat because you said you needed the framing and risk. So now you've got your framing and risk, what are you going to do?
Okay, I probably, until the guidelines came out, would have always ordered an HSCRP as well on a chap like this.
Okay. The recommendations in the guidelines that men had to be over the age of 50.
I know, but to me, he's a metabolic guy. So he's going to have risk for inflammatory.
Okay. All right. So that's certainly a very good idea. Anybody going to start treatment on this fellow with an intermediate risk of framing and risk of 13.4%?
I would talk to him about the fact that he would be a candidate to consider statin.
Okay. So that's I take your reply, and we'll come back to it in future slides. So remember that the Framingham table does have some limitations. One important limitation is that it's not calibrated for all populations. It was devised in a Caucasian population in the eastern part of the US, a very distinct population. Although it may predict risk relatively in all populations, the absolute risk number really only applies to that population. So if it's a Chinese population or a Southeast Asian, particularly a Southeast Asian population, it may be a much higher risk for those risk factors. So it's not accurate for all racial groups. In the young, it generally underestimates risk quite severely. In the old, it overestimates risk. If you do a Framingham risk factor on a 70-year-old, they all come up high risk. So on Framingham, you treat every patient over the age of 70 with a statin, which doesn't make sense. It doesn't take into account competing risks as well. I mean, we have to look at what are the other possibilities of this patient having a health problem in the future. It also doesn't take into account cardiometabolic risk, the metabolic syndrome, pre-diabetes. It's also very bad for diabetes, incidentally, and that's one of the reasons that we'll see there's been a change in the recommendations for diabetes. Inflammatory disease, patients who have just an elevated CRP, but inflammatory disease, for example, with rheumatoid arthritis, with lupus, these patients are at considerable risk of developing coronary disease. It also doesn't take into account renal impairment, which you'll see does impose a cardiovascular risk. And the risk categories are totally arbitrary. You know, 0 to 10%, 10 to 20%, and above 20%. Somebody decided that there was low, intermediate, and high. And it's, you'll see that there is benefit even in treating low-risk patients. So I think that the Framingham risk table does have some limitations, but it's all we've got at the moment that allows us to calculate total cardiovascular risk. So here's our fellow. We've agreed that this fellow fits in the intermediate risk. And the recommendations from the guidelines are that intermediate risk patients you should definitely treat if they have an LDL cholesterol of greater than 3.5, and that's the same as was in the old guidelines. If the LDL is less than 3.5, you should consider other lipids targets, especially when the triglycerides are greater than 1.5. This is new. And so you need to notice this. So other lipid targets, particularly this non-HDL cholesterol. And I'll explain what we mean by the non-HDL cholesterol in a moment. The other possibility is to identify intermediate risk patients who are at higher risk than you imagine, and you can consider secondary testing. And I'm going to go into what I mean by secondary testing in a moment. At the bottom there, you can see how you calculate the non-HDL cholesterol. We get this result without any cost. It's all there, and it's just a matter of simply subtracting the HDL cholesterol from the total cholesterol, and that gives the non-HDL cholesterol. Simple as that. So every bit of cholesterol that's not in HDL is the non-HDL cholesterol. And why is that so important? So this explains this. So cholesterol in the blood is carried largely in association with ApoB lipoprotein, and the ApoB lipoproteins are the ones which are atherogenic. They are not just LDL, which is here, which has the large, in yellow, that's cholesterol. In blue, contained within the particle, is triglycerides. And you can see that with LDL, most of the lipid that's carried in the LDL is cholesterol. Whereas there are other atherogenic lipoproteins, intermediate density, very low density lipoprotein, and chylomicron remnants, which have larger proportions of triglyceride than cholesterol, but are still atherogenic. So if we want to get a total measure of the atherogenic lipoproteins, the non-HDL cholesterol is much better because it includes these lipoproteins than just the LDL cholesterol. And here we've got the HDL cholesterol, so we simply subtract the HDL cholesterol from the total cholesterol, and that gives us the non-HDL cholesterol. And this slide shows how the non-HDL cholesterol in this column compares with the LDL cholesterol, and it refers it to patients who have an LDL cholesterol of less than 2.6 and a non-HDL cholesterol of less than 3.2. And you can see that people who have a low LDL cholesterol but an elevated non-HDL cholesterol have a higher risk. People who have a elevated LDL but a low non-HDL cholesterol have a similar risk to the individual who has a low LDL and low non-HDL, and people who have elevated both LDL and non-HDL also have an increased risk. So the bottom line is that non-HDL cholesterol is a much better predictor of cardiovascular risk than LDL on its own. And it may be in the future that we'll stop measuring LDL. The reason we're measuring LDL still is that the clinical trials have all been based upon LDL. But the great thing about non-HDL cholesterol is the patient doesn't have to fast. The only reason you have to fast is that triglycerides tend to be increased by non-fasting blood, and we calculate LDL cholesterol from the total cholesterol, the HDL, and the triglycerides. So if you've got an elevated triglycerides because it's postprandial, then it's going to artificially reduce your LDL cholesterol. So it's in the future, I suspect we'll be using non-HDL cholesterol rather than LDL, simply because it's, and you don't have to fast to take the blood. You can send the patient to the lab anytime. Now, of course, there are values of having fasting bloods, particularly for glucose, so it may be that we'll want to do it for that anyway, but for cholesterol management, I can see that the future coming that we'll just use non-HDL cholesterol. So, intermediate framing and risk with no compelling indication to treat or not to treat, that's the question. And a lot of the patients you see will have intermediate framing and risk. Their LDL cholesterol is 3.1, and you say, hey, this guy, he's a bit fat, he's got a family history which is not too good, should I treat him or not? So one way of doing that is to use secondary testing. And the secondary testing that came out in the CCS lipid guidelines are using biomarkers and using non-invasive testing. The biomarkers they recommend are lipoprotein A. How many of you can get lipoprotein A? Well, I think we can, except the patient has to pay for it to start with. I can't send them to the lab at St. Mike's and get it done. So it's not generally available, and that's why I've grayed it out. However, we can get a CRP, and this lady recommended a CRP, so that's a reasonable thing to do. We can also look to see whether the patient is excreting albumin, because somebody who's excreting small amounts of albumin is at substantially increased risk. So they do recommend, in somebody who you want to know have they got increased risk, measuring their albumin-creatinine ratio, and the threshold for taking them up to a higher risk is one more than 3 milligrams per millimolar. Now, in terms of non-invasive testing, interestingly, they recommend a graded exercise test. I grade that out because as a cardiologist, I would see that being totally useless in a patient who doesn't have any other reason for doing an exercise test. It's low sensitivity and it's extremely low specificity. The chances are you're going to get a false positive test. Yes?
Does your AC ratio carry the same emphasis here in a non-diabetic as it would in a diabetic?
It does in hypertension, so I think it probably does, yes.
So we should be using it in non-diabetic?
Yes, in hypertensive, certainly. Yeah. It's of the same prognostic value, independent, both in diabetes and in hypertension. So I do not recommend, if you have an intermediate risk patient, doing an exercise stress test to decide whether he's high or low risk. It'll be a very, very low yield unless he's got if he's got an abnormal cardiogram or he's got some symptoms you're not quite sure of. Totally justified, totally reasonable to do it. But if he's totally asymptomatic, he's got a normal cardiogram, and you're just doing it to see whether he's high or low risk, it's a waste of time. Right? Because it'll probably be a false positive, it'll lead to other tests, and you know where that goes. However, looking for atherosclerosis with a carotid ultrasound imaging, just looking for plaque, doing an ankle brachial index, or doing a coronary calcium score is not an unreasonable test in a selected patient group. I'm not suggesting we should do it in all intermediate risk patients, but if you're particularly concerned, that can give you an answer. And this is an example of a carotid artery. You can see the atherosclerotic plaque here. This patient has established atherosclerosis. This would take him up to a high, if he was intermediate risk, would take him up to a high risk. So doing a simple carotid ultrasound can get you very important information. This is a coronary calcium score. You can see the calcium in the arteries, and the Agatston score gives you a measure of how much calcium is there. You can adjust it for age. So if you're at a particular level, then you can say, well, this is 90% of patients of this age would not have a score like this. Only 10% would have a score like this, in which case he's likely to be high risk. And this slide gives the how it's helpful. So this is the relationship between individual calcium score in an intermediate risk individual, somebody who has a, you can see as the calcium score goes up, then the risk of a coronary event goes up. And this, remember, is in patients with intermediate Framingham risk. So if your calcium score is below 50, the chances are you are low risk. But once you get up to 50, you're certainly in intermediate risk, and above 600, you're certainly in a high risk. This is how secondary testing is helpful. The CCS guidelines recommend doing secondary testing in patients who are intermediate risk, who are not candidates for lipid treatment based on conventional risk factors, and where treatment decisions are uncertain. Now, in individuals who are low to intermediate risk, when further risk assessments indicated, particularly in people who have a very strong family histories. And I've seen patients with 3 or 4, 2 sibs and a father have had coronary disease, and they really want to know what their risk is. Somebody who has got a Framingham risk score of 8 or 9 and is Southeast Asian and is 45 years old, for example, and has got impaired glucose tolerance, then it might be a good idea to do some secondary testing to decide whether that patient should go on a statin. So there are patients, but we should be selective. We shouldn't send all our patients. So this is an example of a patient that I saw. So he's a 54-year-old man who was referred for cardiovascular risk assessment, and he'd had his father had had an infarct at the age of 56, his brother had an age of 56, and he was 54 years old. So he was expecting the worst. He had no symptoms. He exercised regularly, running and cycling. He had his limits of medicinal alcohol, and his blood pressure was fine, and his lipids weren't all that bad. You can see his HDL is 2.3, his LDL is 3.2, and his triglycerides were 0.7. So his Framingham risk was 13%. Should he receive a statin?
He could be offered one.
13%. So it would be outside the CCS lipid guidelines.
I know, but the family history is a little more compelling than Framingham in this case.
Okay, I take your point, but it would still, but it would be nice. It would be nice to have something which reinforces the need. Mm-hmm. Okay, or lack of it, for example. So. His CRP was only 1.6, so this is below the threshold which you would normally use for starting treatment. He did have an exercise test done actually before he was sent to see me, not by my orders, and it was fine. He did 12 minutes, he got his heart rate up to 143, and he had no ECG change, totally negative. His carotid ultrasound, though, showed non-occlusive soft lesions bilaterally in his internal carotids, and then plaque in his left common carotid. So that alone puts him high risk and for treatment. You're absolutely right, but you've got something now which is confirmatory. He also had a coronary calcium score which was very high at 743. So he is, no question, high risk, and you have every justification to start this patient on a statin, even though his Framingham risk, his modified Framingham risk score, taking into family history and everything, is only 13%. So it does give you that information. I think we should be using secondary testing, but we should be using it very discreetly because it's expensive, and also officially there's no OHIP billing for it. So if you send somebody for a carotid ultrasound for secondary testing, officially nobody can bill. But I think you can see that I think I've helped this patient by doing these tests. Yes?
Can you review this coronary artery calcium score? I'm not familiar with that.
Okay. So the coronary artery calcium score is a very simple test. It's a CT scan, simple CT scan, one pass, low radiation, 1 millisievert, which, remember, a CT coronary angiogram is about 15 millisieverts. So it's a fraction of a CT coronary angiogram. It's even less than a pulmonary CT coronary angiogram. Sorry, pulmonary CT. It's a very rapid test. You don't have to beta block the patient or anything. You just do a simple CT, and from that they can estimate the amount of calcium in the coronary arteries. From that, based on the patient age, they give you a percentile, or they give you a score, and where that score fits in for a patient of that age, and then you can calculate what their actual risk is. So it's a very simple test. If you do it, you have to ask for a CT scan for coronary calcium score. Now, there aren't many hospitals do it in Toronto. The Toronto General Hospital does it, and St. Mike's does it. But you have to specifically ask for that test. Otherwise, you end up with a CT coronary angiogram if you're not careful, which is a high radiation and a high X-ray contrast dose, and we don't want that. Okay, so this individual, he was motivated in that he had a bad family history, and his father and his brother had an infarct 2 years older than he was. So he was very motivated to go on a statin. But there are other patients who are less motivated, and to have some imaging which shows them that they have a problem, it's one way of motivating them to take a lifelong treatment. And that's actually another point I want to make. I don't know how good you are when you start a patient on a statin and telling them this treatment is for the rest of your life. It is not something that's going to solve the problem in 6 months and then you can go off it. If we start it now, you're taking it for good. I'm very bad at doing that. Patients come into the CCU, have a heart attack, we start them on a statin. I'm very bad at actually telling them that, and I need to do it more. In the office, I think I'm a little better, but in the CCU, I'm very bad at it. And I know that many physicians aren't very good at telling them that this right from the go-get. So they've got to buy into it there and then, that this is treatment for good. And we'll see what the adherence rates to statin treatment are in a moment. They're not good.
May I ask a question?
Sure, with pleasure.
Because we do see a lot of patients like this in our primary care. So my question is...
So you don't see a lot?
We do.
Yes.
We see. So for patients like this, do you recommend us to send them for testing, or regardless if they are very motivated to start treatment, should we still go for the secondary testing or just treat them?
I personally, now that statins are relatively cheap, I think we should have a fairly low threshold for starting statins. I don't think that many of these patients need secondary testing. However, if you have a patient who you're not sure, or the patient is not sure, for example, then secondary testing can reassure them. You know, if he has a coronary calcium score and it comes back 0, I would say don't start the statin even though he's intermediate risk. I'd say it reassures you that this individual does not have significant coronary artery disease and has a good prognosis. So it can be helpful either way.
May I ask another question?
Sure.
Let's say the similar patient, but let's say you see the scan is normal. The patient said, I don't really want to start it. Can I come back next year to do a cardio-like stress test?
There again, looking for ischemia is a very poor indicator of the presence of coronary heart disease. Remember that most patients who develop a myocardial infarction do it on plaques which are not flow limiting. They're not the plaques which cause angina or abnormal scans. So you're not going to pick up those individuals by doing a test for ischemia. So that's why it's a very poor screening test. On the other hand, as I said earlier, if the individual has symptoms which you're not sure about or an abnormal cardiogram, total justification for doing ischemia testing. So, there are high-risk patients, and I want to just spend a few moments talking about high-risk patients. Patients who are at high risk are clearly those who have established vascular disease, whether symptomatic or subclinical. So the patient who's had a heart attack or a stroke or has had an angioplasty, those patients are clear. They need to be on lifelong statins. Patients who you show have vascular disease, either carotid disease or lower limb vascular disease, but now included in this is abdominal aneurysm. They got missed out for some reason. Why we didn't think they were atherosclerotic abdominal aneurysm, I don't know. But they do predict coronary risk and cerebrovascular risk. So now the recommendation for high risk includes patients with abdominal aneurysm. Then patients who have moderate Framingham risk greater than 20%. They are high risk and need appropriate treatment. Now, there's been a change in the diabetes recommendations, and I'll go through those in a little more detail. Now we're recommending that all patients with diabetes over the age of 40 are started on a statin. And I'll justify that in a moment. If they're under 40 and they've had diabetes for more than 15 years and they're more than 30 years old, they should be on a statin. Or if they're less than 40 and have microalbuminuria or reduced glomerular filtration rate, they should be on a statin. So it's essentially over 40 or under 40, so over 40 for all, under 40 if they've had diabetes for 15 years, and under 40 if they've got microvascular disease. Okay?
What's CIMT?
That's carotid intimal medial thickness. You can't get it done anyway,
okay.
So forget it. I mean, carotid ultrasound, that should be, thank you for pointing that out. I did not, they do talk about CIMT in the guidelines. It's irrelevant because you can't get it done anyway. There's very few vascular labs do it, and you certainly shouldn't send it to any vascular lab to do because it's a difficult test to do. You've got to be doing it regularly, otherwise the measurements are probably not worth anything. So the other situation is patients with coronary risk equivalents, and they've now included chronic kidney disease as a coronary risk equivalent, and that is a glomerular filtration rate of less than 40 or microalbuminuria greater than 30. Hypertension with 3 risk factors, and the 3 risk factors are male gender, age greater than 55, a smoker, total cholesterol HDL ratio of greater than 6, the presence of left ventricular hypertrophy, a family history, or an abnormal ECG. Those individuals with hypertension with 3 of those risk factors, they're recommending those are high risk and should be started on a statin. So this individual, I think we would recognize this individual as being high risk. He's no symptoms, he's an ex-smoker, he's got an abdominal aneurysm, albeit quite small. He's got no family history, he's not overweight, he's got a lipid profile really not that bad. But he's got chronic kidney disease with a glomerular filtration rate of 45. His Framingham risk actually is only 5% if you take the actual numbers, but the fact he's got an abdominal aneurysm and he's got a low glomerular filtration rate, I think we'd have a fairly low threshold to causing this patient high risk and starting him on a statin. So I just want to spend a few moments telling you about the diabetes guidelines because these have changed. I was very much responsible for making this change because I felt that diabetes carries the highest lifelong risk of causing or being associated with the development of vascular disease. A diabetic at the age of 50 has something like an 80% chance of developing cardiovascular disease, myocardial infarction or stroke over his lifetime, compared to an individual who doesn't have diabetes, and the risk is about 30%. So it's more than twice the risk in a diabetic individual. So I've said that, lifelong risk 2- to 4-fold. a diabetic individual will develop coronary heart disease 15 years earlier than an individual who doesn't have diabetes. He has a life expectancy which is 10 to 12 years less, and he's got a greater chance of having heart failure, developing a stroke and a myocardial infarction. And when he has a myocardial infarction, his mortality is about twice that of a patient who doesn't have diabetes. So it's a very high-risk situation. The evidence is that the earlier you start treatment in high-risk individuals, the greater the risk reduction. Okay, so we have very good evidence that treating patients with diabetes, lowering their lipids, improves outcomes. The CARD study took patients with diabetes who had one cardiovascular risk factor. I don't know many diabetic patients who don't have a cardiovascular risk factor. Age over 40, and you can see that the study was actually stopped early because of the very dramatic reduction of events, 37% reduction of events, and then the HPS study also took both type 1 and type 2 diabetics over the age of 40, and again you can see a 24% reduction of vascular events there. And in fact, after the CARD study, the conclusion of the study was that the debate about whether all patients with type 2 diabetes warrant statins treatment should now focus on whether any patient can reliably be identified as being sufficiently low risk for this safe and efficacious treatment to be withheld. So in other words, there is good reason for starting diabetic patients, and in these two studies, over the age of 40. So the Canadian Diabetes Association guidelines now recommend that statin therapy should be used to reduce CV risk in adults with type 1 or type 2 diabetes with the following risks. And we've been through those a moment ago, but particularly people over the age of type 1, type 2 diabetes over the age of 40, we're now recommending statin treatment for all. What about chronic kidney disease? This is from a recent meta-analysis of patients with chronic kidney disease and comparing it to individuals who've had a previous myocardial infarction. In green, patients who have both diabetes and chronic kidney disease. In pink, chronic kidney disease on its own. In blue, diabetes on its own, and then the purple at the end, people who have no diabetes or no chronic kidney disease. You can see that diabetes, the combination of diabetes and chronic kidney disease is very bad for, this is causing cardiovascular disease. You can see if you've had a previous myocardial infarction, the risk of mortality and another infarct is substantial. And you can see now that chronic kidney disease, all-cause mortality, is as bad as somebody who has had a previous myocardial infarction, but myocardial infarction isn't quite as bad, but it's at the same level as individuals who have had diabetes. And it's based upon these types of studies showing that chronic kidney disease is as bad as patients who had previous myocardial infarction, that its chronic kidney disease has been called a coronary heart disease equivalent. And it was for that reason that the guidelines now recommend that chronic kidney disease with a GFR of less than 45 or microalbuminuria be called a coronary heart disease equivalent, and you start the patient on a statin. There is evidence now to suggest that reducing the cholesterol in this population is beneficial. This was from the SHARP study, where the combination of ezetimibe and simvastatin reduced events by 17%. So the management of the high-risk individual, the goals, first of all, in a high-risk individual, please start the patient on a statin. I think in a high-risk individual, we shouldn't be saying, well, I think you should get your weight down, you should exercise more. This high-risk individual, I think we should do that. We should go for lifestyle changes, but at the same time, we need to initiate a statin. Yes?
Are you pleased about the recent changes in ASA and high-risk patients who've never had for primary prevention?
Okay, so ASA is particularly in diabetic individuals. The benefit of ASA for primary prevention in diabetic individuals is totally unproven, and in the CDA guidelines, even the 2008 guidelines, we recommended that ASA not be used generally for primary prevention. I think a few patients it's justified. If you've got a very high, if you've got many additional risk factors in diabetes, then it's reasonable to do it. But otherwise, the risks of the aspirin probably exceed the benefits. It may be that aspirin, the doses we use, does not work in diabetes at all. So this is the high-risk individuals. The goals are the same as they were before, the 50% reduction of LDL, a target of less than 2, or now the alternative target of getting the the non-HDL cholesterol less than 2.6. So you need to remember another number now. And that's that if you're going to treat non-HDL cholesterol, it's getting the non-HDL cholesterol to less than 2.6. And statins are very effective in getting the non-HDL cholesterol down to target. So there are patients who fail to achieve these lipid goals, and patients who are not at target despite using an optimal dose of an effective statin. And quite frankly, today, I don't think we should be using anything other than atorvastatin and rosuvastatin. They are the most effective statins. They're now both generic. And I think that they are, we should not be using the other statins today. Not only simvastatin, for example, is the toxicity of simvastatin is much greater than the other statins. The other statins, pravastatin, is a very weak statin, and so I don't think there's a justification for using them. I personally have stopped using. I use rosuvastatin and atorvastatin all the time. However, there are patients who do not achieve the recommended goals on a statin alone, and so your options to lower LDL cholesterol in that population is to double the statin dose, to add ezetimibe, to use niacin, or a bile acid sequestrant. Fibrates do not reduce LDL cholesterol, so there's no point in adding a fibrate to reduce LDL cholesterol. So you can see that doubling the statin dose generally will only reduce the cholesterol by about 5 to 6%. And if, for example, you're on 20 milligrams of rosuvastatin, going to 40 milligrams, you're lucky to get an additional 5%. The maximum benefit from a statin is on the starting dose, and you get 5 to 6% additional by doubling from that. Ezetimibe, a variable response, but somewhere between 15 and 25% usually. Niacin, you're lucky to get 20%. You may get a 14% reduction. Remember that the AIM-HIGH study showed absolutely no benefit of adding niacin to people who had been optimally treated with a statin. So question the trouble that you've got to go to persuade your patient to take niacin, because they hate it. It causes flushing. It's very uncomfortable. Bile acid sequestrants, it's a reasonable thing, but they're not very effective, and they've got to take large volumes of the stuff, or a large number of pills, and they're very expensive. So I think your best bet, if you don't succeed with the optimal dose of a statin, is to add ezetimibe. How often do we need to do this? Well, this is at a rehabilitation clinic in Alberta, and 28% of patients needed to add an additional treatment, and you can see that the commonest treatment that was added to their statin was ezetimibe. And doing that, Dr. Senaratne was able to achieve an LDL cholesterol of less than 2 in 85%, which is pretty good going. I don't need to tell you that ezetimibe is a cholesterol absorption inhibitor. It reduces the amount of cholesterol returning to the liver, reduces the liver pool, and in combination with a statin is a very effective reducer of LDL cholesterol. And in fact, in the Explorer study, this at the bottom is what you probably need to take notice. The combination of rosuvastatin 40 milligrams and ezetimibe 10 milligrams reduced LDL cholesterol by 70%. So a very powerful reducer of LDL cholesterol. There is now quite a lot of additional safety data of adding ezetimibe to a statin, and this is a recent paper from this year where they looked at 11,000 patients on the combination of statin and ezetimibe, compared it to statin alone, and you can see there was no difference in adverse effects in the incidence of hepatitis, gallbladder disease, allergic reactions, or muscle-related adverse effects. So it did not increase the toxicity of the statin, and there was no additional toxicity by using ezetimibe. It's a safe combination. So finally, what about the low-risk patient? One of the concerns with the low-risk patient is that the adverse effects of the statin combined with the exceed the benefits. And the low-risk patient we've generally defined as a Framingham risk score of less than 10%. Do these patients firstly benefit from statin therapy, and what's the benefit against the risk of treatment? Well, the cholesterol treatment trialists collaboration this year published a very important paper on the impact of LDL cholesterol lowering with a statin across the range of risk. And these are the risks less than 5%, 5 to 10%, 10 to 20%, and 20 to 30%. And you can see that the risk reduction is pretty much the same. So overall, there was a 25% reduction for every 1 millimolar reduction of LDL cholesterol. And I should point out that with modern statins like rosuvastatin 20 or 40 milligrams, we're often able to lower LDL cholesterol by 1.5 or even 1.8 millimolar. So you get a lot more than a 25% reduction. So you can see that at the 5 to 10% range, you're getting at least a 25% reduction for every millimole reduction. And then a 15% reduction in mortality overall. And you can see the point estimates are fairly constant for that. Obviously, there's far fewer deaths than there are cardiovascular events. But overall, there's this reduction in mortality. So the benefit against the harm in the treatment of individuals at risk at a 5 to 10% Framingham risk, for every 1,000 individuals treated, a 1 millimolar reduction of LDL cholesterol over 5 years results in 11 less major vascular events. And that's a small risk. It's estimated that there would be 1 in 2,000 hemorrhagic strokes, and that's extremely controversial. There are meta-analyses which show absolutely no increase in hemorrhagic stroke. 0.5 or 1 in 2,000 major myopathies, and 1 in 10,000 of rhabdomyolysis. Very difficult when figures are as small as that, because rhabdomyolysis occurs spontaneously in the population anyway. And then the major risk, and I put it in quotation marks, is a potential of new diabetes. Do statins cause diabetes? There is a signal, but the patients who develop diabetes, the vast majority of them have metabolic syndrome, and they were probably going to get diabetes anyway. So it's probably not a major hazard. So if you take diabetes out, you have this very tiny risk for a significant benefit, and incidentally, no signal of an increase in cancer risk at all. So the question is, you know, many of these patients would not be included in current guidelines, and certainly not in the Canadian lipid guidelines. However, there appears to be a benefit even in these low-risk individuals. So the low-risk individuals, the current guidelines recommend, and these haven't changed at all, is that pharmacotherapy, when the LDL is greater than 5, or if the patient has a genetic dyslipidemia, for example, familial hypercholesterolemia, and those patients, we recommend a 50% reduction of LDL. There's no actual target. We want to get that LDL down by 50%. So, what about sticking on treatment? How good are we at getting patients to stick on treatment to prevent them developing vascular disease? And this is a recent paper looking at, in a huge population, looking at how well patients stay on medications. And you can see this is for primary prevention on this side, this is for secondary prevention, and for aspirin, for ACE inhibitors, for beta blockers, for diuretics, for statins. And you can see that for primary prevention, it's around about 50 to 60% of individuals will still be on the statin at the end of 1 year. For secondary prevention, it's a lot better, and you can see for statins, about 75% of individuals will be on a statin for 1 year. There is a study from ISIS which looked at patients over the age of 65 in Ontario, and Cynthia Jakovicius estimated that only half of patients over the age of 65 who were started on a statin were on the drug at 1 year. So it may be the elderly are not quite as good as that. And maybe some of those were primary prevention as well. So drugs don't work in patients that don't take them. So you've got to encourage adherence to treatment. As I've shown you, about a 50% adherence in primary prevention. And you've got to use methods of persuading our patients that the drug is good for them. We've discussed about vascular imaging and showing that the patient actually has atherosclerosis, and in certain situations I think that is very beneficial. Another way is to actually tell them how old their arteries are. There was a English fellow called Thomas Sydenham in the 17th century who actually coined the phrase, "You are as old as your arteries." So your number of candles on your birthday cake may not tell you how old your arteries are. They may be a lot older than that tells you. So if you can give them an idea how old their arteries are, it might persuade them that they need to do something to rejuvenate themselves. So calculating vascular aging might be an issue. The other thing we can do to try and get patients to be more adherent is to manage well adverse effects. So the concept of vascular age is not a new one, but it's one which has been applied in the new guidelines. So this is an individual whose chronological age is 50 years, and we calculate what his life expectancy is, and we calculate that it's 25 years. But in fact, the average 50-year-old has a 30-year life expectancy. So he's got a life expectancy which is 5 years less than an average 50-year-old. So his vessels have advanced 5 years. So his vascular age is now 55 rather than 50. So you tell him, hey, you've only got 50 candles on your birthday cake, but your arteries are at least 5 years older. You need to do something about this to encourage you to live a little bit longer. And there is a table in the new guidelines which you put in the cholesterol, and it's for smokers, for diabetes, and their blood pressure, and you come out with what their vascular age is. And it's quite fun looking at it and seeing what sort of numbers you get. And here's the age. These are the age down here for different blood pressures, for different cholesterols in smokers and non-smokers, and presence or absence of diabetes, and that's the tables for males. So finally, adverse effects. This, I was honoured to be a participant in the development of this position paper on the management and prevention of statin-related adverse effects. And we came out with a number of recommendations, and this has actually been quite well received. So there are many adverse effects which have been reported. Some are real, some are not real. Whether alopecia is caused by statins, I don't know, or erectile dysfunction. Proteinuria has been described with some statins. Neuropsychiatric effects have been very difficult to prove. I know there's a black box from the FDA about memory impairment, but there are, when studies have been formally done to look at the effects of statins on memory in the older patients, and they did that in the PROSPER study in patients over the age of 80, they didn't detect any impairment. Yet there is a black box on that. And the same applies to fatigue, hemorrhagic stroke, as I've told you. The meta-analyses which are out there don't show any increase in hemorrhagic stroke. New diabetes, it's about a risk of 1 in 300 or 400, and those patients anyway probably are going to develop diabetes. Cancer, there's absolutely no signal. Elevated hepatocellular enzymes, raised transaminases, it's usually a very minor increase, and there are no reported cases of acute liver failure on statins. So muscle-related adverse effects occur, muscular symptoms occur, according to registries, about 1 in 10 patients. And they could have muscle aches, weakness, stiffness, and cramps. And most patients do not get an increase in CK. I think a lot of them are related to the statins. I think a lot are not, and I think the worst enemy for statins is the pharmacist who tells the patient that this drug is going to make you have aches and pains. Sure enough, they've had aches and pains for years. They've now got something to blame their aches and pains on. They do, certainly, these aches and pains do compromise the quality of life of a number of patients, and I think they have an impact on medication adherence. So the guidelines recommend that the overall risk and benefits of statins greatly outweigh any risks or adverse effects. And the risk of new onset diabetes is small and not a reason to avoid treatment, even in patients who are at risk of developing diabetes. If patients develop statin-related symptoms, stop the drug. If the patient will allow you, reinitiate it at a very low dose. So I'll reinitiate rosuvastatin at 2.5 milligrams and gradually build it up. And most patients, I find, can tolerate it. This was a table which is from our position paper, and I'm not going to go over it now, but it essentially tells you how to manage according to what the CK level is and how to restart drugs and initiate and what to do if patients have very high levels of CK. So this is the final slide, that the CCS lipid guidelines recommend that you assess all patients at risk and you do fasting lipids to assess the Framingham score to determine the risk level and the need for treatment. Up to 20%, we should consider non-HDL cholesterol for a threshold and a target for treatment. And in some patients, in selected patients, consider the use of secondary biomarkers and imaging to decide whether treatment is necessary. Statin treatment for high risk, irrespective of the baseline lipid levels. I haven't gone into this, but we should ignore, if a patient's high risk, their baseline lipids are too high for them. Remember that the LDL cholesterol is usually very misleading. The actual level is misleading in terms of the atherogenicity of the lipid. LDL cholesterol comes in large buoyant particles or tiny dense particles. Those small dense particles are very easily oxidized or glycated. They are very atherogenic. And you may have exactly the same LDL level as somebody who has large buoyant non-atherogenic particles. So the actual LDL level in a high risk, particularly in a high risk patient, is very misleading. So you should treat LDL irrespective of what the level is in a high risk individual. Statin, and particularly with patients with established atherosclerosis, including those with an abdominal aneurysm, in diabetic patients over the age of 40 with chronic kidney disease and hypertension and three vascular risk factors. Thank you very much. It's getting late, but I would be very happy to answer any questions. Thanks, Jimmy.